And really, when do we use ultrasound, CTA, and MRA before going to the lab? I think it's important when you look at imaging a patient with CLI, why are we doing it? I would say we're assessing the amount of disease, the severity of disease. Is there arterial insufficiency? What's the extent of that disease? And try to make a decision whether the arterial flow is sufficient or whether we need to revascularize. And I think that's important because at that point, if you make that decision, then you may proceed with this advanced imaging to help you plan that intervention, let you know where the anatomic levels of diseases are, and then get more information to help with your treatment. I think we've already heard a lot about the importance of that initial assessment, physical examination, ABI, TBI, arterial PVR, and segmental pressures. Really, all that kind of goes into that initial idea assessment to, all right, is there some type of vascular insufficiency? Is it in the equation for that wound? And once we make a decision that that patient requires revascularization, then that's when I think an MRA or CTA is helpful. We've already seen this graph several times, this algorithm of what to do in testing. And I think it's important. Same kind of, at the end of the day, it really says that down here, that once you make that decision that the patient needs revascularization, then you're going to proceed with that duplex ultrasound, CT, MR, and hopefully not need a diagnostic angiogram, but sometimes you do. So what's the role of duplex ultrasound? We've already pretty much seen how it may supplement a PVR segmental pressures. It helps us assess flow by waveform and velocity analysis, but also gives us an idea, is there iliac disease by that waveform in that common femoral artery? What does the common femoral artery look like? It really helps us, and I start planning when we see disease, how we're going to approach that revascularization. And really the duplex map, really almost a drawing, is really helpful. When do we get a CTA or MRA of these patients? And I think, to me, it's when we're going to think about treatment plan. Really give me a direct morphologic evaluation of what's going on so I can decide what's my site of access. Does the patient need surgery or bypass, or is this an endovascular approach for this candidate, for this patient? What are my runoff vessels? What's really the goal of my therapy? What am I going to tell my patients in terms of risk? Do I have all the tools that I need to approach this particular patient at the time that I'm going to treat it? And what I really hope is that's going to reduce my procedure time, my contrast use, and my complication rate. Why CTA? I think CTA is very helpful in that it's isotropic imaging. What that means is that these images, these images, in any way we look at it on a workstation, it keeps its actual information. So we're able to look at curved planar reformats through the vessel. We're able to perform volume rendered images. We're able to do a lot more. We're able to look at the wall, calcium, soft plaque, as well as the vessel or the lumen. So I think this is really important. There's a study that looked at patients with CTA. Most of these studies, however, are done on claudicants. So it's kind of a skewed population. But it looked at 212 symptomatic patients. It allowed basically a differential, able to distinguish which patients should go to endovascular therapy, which patients needed surgical therapy, and which patients needed a hybrid approach. Here's an example of a patient who's had a distal bypass to the distal popliteal artery. You can see here a CTA evaluation of it. You can see that jump graft. This is what it looked at angiography. So again, gives us a morphology and assessment of what that vessel is going to look like before we're there. Here's another patient with severe claudication. You can see these are basic rocks in the common femoral artery. Don't really want to approach this from an endovascular approach. Here's another patient with a complex left iliac lesion and also a occluded femoral artery on the left leg. Being able to look at these images and say, I'm going to approach this from the right side, come up and over, stay away from the left groin, and see if that's sufficient to help this patient with a left foot ulcer. You can see that treatment. When you're looking at the small vessels, again, patient with minimal calcification, but you can see a good opacification of the distal tibial perineal trunk, being able to then say, okay, we're going to treat that tibial perineal trunk, and then it's assessment after we treated it. But there's limitations when we look at CTA for CLI, and that's because a lot of our patients have renal insufficiency. They can't afford the adnated contrast material, and when we assess the infrapopliteal vessels, we need to distinguish between calcium and contrast, or the vasculature. And sometimes it's very difficult in these very small 2-millimeter vessels. And you can tell patients with CLI have a lot of distal disease and occlusions. So this is really where I think MRA is a study of choice. It provides a great assessment of the otoiliac and femoral vessels, but along with time-resolved imaging, allows you to really get an assessment of what those infrapopliteal vessels look like. Unfortunately, it uses gadolinium, so patients with any renal insufficiency aren't candidates. It doesn't really tell me about calcium, and has artifacts in terms with stents and metal artifacts. However, it's not always also as reproducible and available as CTA. So that's why we kind of go towards CTA, because there's just those obstacles that we need to eliminate for MRI studies. By time-resolved imaging, this is what I'm speaking about. These are images that basically it's 4D imaging, volumes of information being acquired every 2 to 3 seconds, so I can really get an idea, how does that flow down those tibial vessels? And this is really, to me, the most important part of performing a really good quality MRA in these particular patients. So you can see here, one of these time-resolved examinations, be able to slow it down. You see where the lesion is, and that's what we found at times of angiography. Again, we were ready to prepare. We were prepared to treat that patient because we kind of knew what we were going to expect. Again, tibial pedal evaluation, you can see here, because it's a volume of information, you can then look at it from a coronal sagittal reconstruction, as you can see here. You can see that DP occlusion, and you can plan on treating that appropriately. Again, this would be a patient where the ABI would be normal, and then you're looking at abnormal TBI. And really, so we talk about hybrid imaging. So when do I consider CTA versus MRA? Really, MRA, if I have a GFR, estimated GFR over 30, patients that have iodinated contrast allergy, but really I'm looking for my older patients with CLI. These are patients that are calcified vessels, patients that have cardiac disease, because I'm going to be able to look at those small vessels below the knee. CTA, I reserve really for evaluations of inflow lesions, patients that may have stents or pacemakers or contraindications to MRAs. So these are the patients that I go with CTA, particularly if they're able to tolerate the contrast. Dialysis patients can't get an MRA, but they can get a CTA. What's coming down the pike is non-contrast sequences. So you can see here non-contrast evaluation of the renal arteries, non-contrast evaluation of the infrapopliteal segments. These are great imaging studies. This is where we need to go because of the issues with gadolinium. However, they look great in normal patients. They just were not there when it comes to patients with disease. Recent study published in JACC, again, looking at KISS sequences, a different type of sequence, really motion, it helps eliminate motion problems, and then being able to assess these. I think this is where we need to go with this type of work, looking at patients with CLI. This study was really mostly done, again, in claudicants. So why CT or MRA for a CLI? There's less risk to the patient than a diagnostic angiogram, less radiation to me as the performer of the angiogram, easier to order, cheaper than an angiogram, and I can manipulate that data. I can take all the time I need to really make my plan before I go into the cath lab. The present status is that we have a benefit of CT or MRA, but we're just not well documented. In this sense of this world where we need to really know what is cost effective, we really don't know how effective these pre-procedure MRAs or CTAs are. The variability at a local level is quite high. You don't know if your test is available at certain hospitals. You don't know what kind of test you're going to get. And there's also the patient factors that are involved. And then how are these results being utilized? And when are we ordering them? When's the right time? And I think it's when you make a decision that you're going to revascularize the patient. We really lack a universal imaging algorithm, and that's something that we need to go so we can benefit. Recent study really showed national variation, and you can see that when they looked at that, not many hospitals are performing these kind of examinations, advanced imaging examinations. So I think we do need some national algorithms. So when do I choose? I think this is really a repetition. Calcified vessels, I prefer an MRA over CTA, particularly with time-resolved imaging, limited with contrast, but CTA does give me a higher spatial resolution. So with that, thank you very much for your time.